Hello everyone. Hello again at Bioptická multi-head session. My name is Marian Schweidler. I will show you today only two cases. One is a very simple and easy one. The second one is very rare and quite interesting. And the first case, as you can see, is small intestinal biopsy coming from duodenum. It's a 48-year-old male patient. I don't know what the clinical symptoms are, but probably there is some kind of malabsorptive syndrome going on in this patient. And as you can see, this is duodenal biopsy, and even in this very low magnification, you can see that the mucosa is not normal looking. Epithelium is completely normal, but abnormal thing is lying down there in the lamina propria. The lamina propria is completely filled with these foamy macrophages. And additional thing you can see here are these dilated cystic spaces. Most of these will be, if we will stain, will be dilated lymphatic channels. And this is how this disorder causes malabsorption by blockage of lymphatic vessels in the small intestinal mucosa. If you stain these macrophages by histochemical stains, you will have very strong PAS positivity, and this is very typical example of Whipple disease caused by Trophorima whipplei, which is intracellular bacteria causing this accumulation of foamy bacteria-packed macrophages. We have it was sent as a consult case to confirm the presence of Trophorima whipplei by molecular genetics, and it was positive. Sometimes these macrophages you may find them even in gastric mucosa biopsy or large intestinal mucosa biopsy, or even in esophageal biopsies. So and then the involvement of the mucosa is more subtle, so there are not that many macrophages present there. So you have to be careful not to miss a diagnosis of Whipple disease. I've got also lymph node biopsy from this patient. It's from, I believe, from axilla. So you can see this lymph node. And again, sinuses are packed, filled completely by these eosinophilic macrophages. If you stain them by PAS staining, they will be all positive. Sometimes in the lymph nodes you can see these dilated lymphatic channels. It's not present here in this biopsy. And again, you should not miss a diagnosis of Whipple disease, because untreated Whipple disease is lethal in up to 100% of cases. Okay, and the symptomatology, clinical symptoms of Whipple disease are many times very non-specific, and the course of the disease is very, very long, and eventually clinicians start thinking about the disease, and then they perform biopsies, and the role of pathologist is not to miss and to confirm the diagnosis. Okay, the clinical presentation is many times non-specific, but many patients have malabsorption syndrome and neurological symptoms and cardiological symptoms. It can involve almost any organ in the body. So Whipple disease. And my second case is a biopsy from a 34-year-old male, and it's a lesion, intradural L1, L4 lesion. So it's central nervous system biopsy. And in this low magnification, you can see something which looks a little bit organoid, adenoid, or angiomatoid pattern, trabecular pattern, and a little bit solid. It's a well-circumscribed lesion, non-infiltrative, and the specimen was composed only by tumor cells. And in high magnification, you can see these relatively cytologically blunt cells with brown nuclei, salt and pepper chromatin, eosinophilic cytoplasm, forming these perivascular pseudo-rosettes-like structures, a little bit reminiscent of ependymoma, and trabecular structures, or let's say adenomatoid structures. Okay, but in other parts there is more solid and nested growth pattern. So in my eyes it looks a little bit like ependymoma. Okay, it could be ependymoma, but the cytomorphology looks endocrine. Okay, and maybe with this solid and nested pattern growth, a little bit paraganglioma-like. And in fact, if you stain for synaptophysin or chromogranin, it was this diffuse positive. The lesion also stained for INSM1 antibody, its nuclear transcription factor, so it looks, the phenotype is neuroendocrine. And by staining SOX10 or S100 protein, you will have this peculiar staining pattern. These are sustentacular cells. So the phenotype is like paraganglioma, but GATA3, which is positive in all paragangliomas, is clearly negative. And in contrast to regular paraganglioma, you have this diffuse cytokeratin immunoexpression, and this immunoexpression shows this very interesting dot-like positivity. So neuroendocrine markers are positive, cytokeratins with dot-like positivity, sustentacular cells are positive with a little bit of paraganglioma morphology. And the lesion was called before cauda equina paraganglioma, and now in new WHO classification is called cauda equina neuroendocrine tumor.
We have two cases, I guess.
So this is my maybe third or fourth case. This is in-house case, but previously I have saw these cases in consult, and always it came as misdiagnosed as other lesions, as ependymomas or other stuff. Importantly, these cauda equina neuroendocrine tumors or paragangliomas have nothing to do with other paragangliomas. So when you have paraganglioma outside the setting, cauda equina, you should rule out some systemic syndromic association. So these are never succinate dehydrogenase deficient, never fumarate dehydrogenase deficient, never associated with any kind of syndroma. And in other settings, you always have to perform immunohistochemistry, and clinicians should rule out syndromic association. So these cauda equina paragangliomas, or new term is cauda equina neuroendocrine tumors, are never associated with any kind of syndroma. And in fact, also by methylation profiling and immunohistochemistry, these are completely different tumor. And I will show you one paper. It's the most comprehensive paper ever published about this entity, and it comes from the group of authors led by Jirka Soukup, is a very good friend of us, pathologist working in Prague. And they collected 23 cases. It's the biggest paper on this entity. There are probably 300 cases published up to date. And here you can see the whole spectrum. So sometimes it completely mimics regular paraganglioma with this cell ball nested architecture. Sometimes it shows this adenomatoid or angiomatoid or trabecular papillary formation. Sometimes it's sclerotic, and very rarely it may have Schwannian stroma there and gangliocytic differentiation. So this is a little bit reminiscent of another interesting and rare lesion, and that is duodenal gangliocytic paraganglioma. So in some cases with this Schwannian component and gangliocytic component, it's morphologically very much the same, like the duodenal tumor, but it's again completely different entity. Sometimes you may have this ocell invasion. It means nothing. There are no cases on report which metastasized. Maybe one or two cases recurred, maybe after incomplete resection. So it's completely benign lesion. And importantly, what is most important to use in differential diagnosis, GATA3 immunonegativity and cytokeratin positivity distinguishes that from metastatic paraganglioma. And that's it from my side.
So hello everyone, here's Greta Mikhalova. I have 4 cases for you, and the first one is a consult from Slovakia, and it is woman 1976 born, and clinically it was sent with a diagnosis of leiomyomas. And here is morphology of the leiomyomas, and I got to review 19 paraffin blocks from the tumor, and almost all of the blocks look the same in this fashion. So what we can see, it is spindle cell tumor, which is composed from atypical cells with almost bizarre, very large and pleomorphic nuclei. But if you want to search for other aggressive histological features as mitotic activity, infiltrative growth, presence of tumor necrosis, and maybe others, atypical mitosis, there was none of these features throughout the whole tumor. So this is a quite typical example of a well-known lesion called leiomyoma with bizarre nuclei. And as we have the tumor like this, you know that there is a subset of uterine leiomyomas with bizarre nuclei which are connected to FH deficiency, some of which are part of the hereditary leiomyomatosis renal cell carcinoma syndrome. So it is good to look for the features which can be helpful to exclude the presence of this syndrome in this particular patient. So the morphological features connected to FH deficiency are Staghorn vessels, which we can see here. Another helpful features are the nuclear features, the presence of eosinophilic nuclei, which I didn't found throughout the lesion. Also, the presence of areas similar to alveolar lung edema, which were not presented as well. And I'm not aware of another features. Maybe you can help me with which are another features. I don't know. Okay, so overall, these features were not present morphologically, but only the Staghorn vessels. But despite that, I performed immunohistochemistry for FH. This is FH. And in case of the suspicion for a syndrome or for somatic mutation of fumarate hydratase gene, there will be a loss of staining, and you can see here that this is not the case. The staining is retained, so there is cytoplasmic positivity in lesional cells throughout the whole lesion. And another helpful marker for FH deficiency is 2SC, and I thought I performed that as well, but maybe not. Okay, I couldn't see it here, so maybe I left it in my microscope upstairs. But there was no positivity in 2SC, so this was not probably leiomyoma associated with FH deficiency, either a sporadic mutation or germline mutation. It was discovered quite recently that there are two subsets of leiomyoma with bizarre nuclei, one of which is this with FH deficiency, and another one is leiomyoma with bizarre nuclei having either or having loss of RB or retinoblastoma 1 staining. I am showing you here the immunohistochemistry with RB1 protein, and you can see that it is lost in lesional cells. Sometimes it is quite hard to interpret this staining because you have to interpret the valuable finding as a negativity. So, but in this case, it works quite well. So there is a loss of RB1, and this was the case which was representing another subset of uterine leiomyomas with bizarre nuclei, those having RB1 deficiency and also TP53 or P53 aberrant expression. This is P53 staining, and there was overexpression. The second subset of leiomyomas, so those RB1 deficient or TP53 mutated or P53 abnormal, can have either just one feature or both of them. So this was another subset of leiomyoma. So in this case, there was no additional workup for the patient, and we can close this up as leiomyoma with bizarre nuclei, so-called type 2. Another case was clinically a polyp of the uterine cervix. The patient was 22 years old, and the lesion looked like this. I had 10 blocks, and every block was the same. So here we have the morphology of the lesion. It was ulcerated on the surface. So here is an inflammatory exudate covering the ulceration, and as we go to the deeper parts, you can appreciate these lesional cells, these spindle cells. There are hypercellular areas alternating with more myxoid or hypocellular areas, and these tumor cells are sometimes forming clusters, and sometimes they are gathering around vessels or in another areas around entrapped or around non-neoplastic glands. So this is a soft tissue lesion. These are non-neoplastic endocervical glands. This is another one, and the lesional cells are here forming the clusters. And immunohistochemically, there was a positivity for this is MyoD1, highlighting the neoplastic tumor cells for forming the clusters. So MyoD1 positivity, PAX7 was also positive, which is this staining. Yes, good question. So this from based on morphology and immunophenotype, this was concluded being embryonal rhabdomyosarcoma, and we then did immunohistochemistry. There was DICER1 mutation, so the patient was recommended to undergo molecular testing regarding this lesion being part of DICER1 syndrome, and this is an examination which has to be conducted by a clinical geneticist. So we don't have the result from this consult from this genetic counseling yet, but there was DICER1 mutation present. So embryonal rhabdomyosarcoma with DICER1 mutation. Another case is a uterine lesion. 23-year-old woman with uterine lesion and with anamnesis of pregnancy, which we can also see in this biopsy even without this anamnesis, because there are chorionic villi, and this proliferation so here we have areas of quite atypical epithelioid cells together with fibrinoid necrosis, and here would be the main differential diagnosis, placental-site trophoblastic tumor and choriocarcinoma, because this lesion is quite cytologically atypical. But for the diagnosis of choriocarcinoma, I think the most helpful facts are the fact that this is non-molar pregnancy. As you can see here, there are normal chorionic villi without atypical proliferation of trophoblasts, which is one helpful sign. There is no need to focus only on the neoplastic lesion to decide what lesion is what type of neoplasm is this. So non-molar pregnancy together with levels of human choriogonadotropin, which were low in this patient, so not alarming the diagnosis of choriocarcinoma. And third, you will have to focus on the morphology and also immunophenotype of this lesion. So these are mainly intermediate trophoblasts. And for choriocarcinoma, you'll have to see mononuclear cytotrophoblasts, which are required for diagnosis of choriocarcinoma, and also multinucleated trophoblastic cells. This is quite a typical area of, I still think, intermediate trophoblast. There were areas having multinucleated cells, which could be either cytotrophoblasts or multinucleated intermediate trophoblasts, and this was probably the latter, because the multinucleated intermediate trophoblasts have usually oval shape, and syncytial trophoblasts are more irregular in their in its shape. For placental site trophoblastic tumor, which I think is the diagnosis in this case, there is also the presence of fibrinoid necrosis. In case of choriocarcinoma, there is usually presence of very pronounced tumor necrosis, which is almost overrunning the viable neoplastic tissue. This lesion was immunohistochemically positive for GADA3, which is the staining. It's typical for placental site trophoblastic tumor. PAX8 was negative in the lesion, which also corresponds to that. This positivity is retained only in Müllerian epithelium, which is of course positive, but the lesional cells are negative. Placental site trophoblastic tumors are tumors which in most cases behave indolently, but approximately 10 to 15% can metastasize most frequently to the lungs, but also to another sites. And because they here where the morphological ITP are quite severe, and also the proliferative activity was high, here is the probability in this case that this might behave aggressively. This might belong into a subset of more aggressively behaving cases. These were 3 cases from gynecopathology, and the last case is only a case from routine biopsy and from completely different field. It is not my field, but I got a frozen section from the brain from old woman, and the request from the clinician was either primary tumor or metastasis, so very helpful. And in frozen section we see this proliferation. When I called with clinician, one thing I want to show is that this is solid tumor, overtly malignant, and here is a pigmentation which alerted me that this might be melanoma, because but you don't know if it is hemosiderin or melanin, but because this is quite dark, I thought this could be melanin. So I asked the clinician if this is melanin and thus melanoma. He told me that the patient does not have any anamnesis of melanoma. So I told him that the differential here is probably secondary malignancy. We don't know if undifferentiated carcinoma, lymphoma, or melanoma, and less probably a high-grade glioma, which I think, Marianne, is not very probable from the morphology, but this was the differential. This is HNB45, which was positive, and also S100 was positive. So this is a metastasis of melanoma into the brain, despite the patient did not have any anamnesis, or they weren't aware of that, but maybe the patient had excised melanoma many years ago and didn't mention that to the clinician. So that's it from me. So
hello everybody, it's Michal here. I have mostly some basic soft tissue cases. The first was a adult male tumor on the thigh. So very poor clinical information, no information about size or anything else, and also very poor material. So you can see just skeletal fragments of skeletal muscle, some adipose tissue, and then these small fragments which consist of mostly sclerotic stroma and some bland ovoid spindle cells, which on higher power look very bland, very benign, no mitotic activity. Very hypocellular lesion. And in some areas, you can see the nuclei are elongated, a little bit wavy. And in yet other areas, you can see something that looks like cytoplasmic processes, such as here in the center. There was one more block, but it didn't look much better than the one before. But this one fragment was the best we got. Again, very similar, hyalinized stroma, bland spindle cells. And then, perhaps more beautiful than before, these cells with long cytoplasmic processes here also. So the differential here, it looks like a mesenchymal tumor. It looks like a more likely benign mesenchymal tumor. We still have to think about some malignant mesenchymal tumors, some sarcomas, which can look bland, such as low-grade fibromyxoid sarcoma. That's number one to exclude. But otherwise, we can think of some, benign mesenchymal tumors with a lot of sclerotic stroma. So maybe fibromatosis, desmoid fibromatosis, which is unlikely here based on the morphology, and and that's the one I favored, some neurogenic tumor. So basically, you go on with the basic immunohistochemical panel for non-descriptive spindle cell lesions. So S100 protein, CD34, EMA, desmin, smooth muscle actin. You can add cytokeratins perhaps, although here it's unlikely. So S100 was negative. This is CD34. I mark the small fragments as not to spend time here on it. And CD34 is positive in the vessels, but also it seems quite nicely positive in the spindle cells, and especially in the long cytoplasmic processes. So CD34 is not a very specific marker, but it's very good for picking up vascular differentiation, and also it's quite sensitive for many tumors such as dermatofibrosarcoma protuberans, solitary fibrous tumor, superficial CD34 positive fibroblastic tumor, and also it's actually a very good, very sensitive perineurial marker. So whenever you have strong CD34 positivity, especially when it's in those long cytoplasmic processes, think of some perineurial lesion. But of course, it's not specific, so it's good to add something more specific for perineurial differentiation. This is EMA, and again, you can see nice positivity, especially, again, the long cytoplasmic processes are highlighted by EMA. So this looks like a perineurioma. Morphology is perfect. Immunophenotype is as good as it gets. There are also other perineurial markers, because very often you get either negative or kind of ambiguous EMA staining. Always go on the highest power to check for EMA positivity, because very often it's focal or faint. So the other markers, this is Claudin 1. It's perhaps the most specific perineurial marker, but the least sensitive. But in this case, this is perfect positivity. It's a little bit granular. That's normal. So this is Claudin 1. And then the most sensitive but least specific perineurial marker is GLUD1. I need to find my marking. So here, GLUD1. Again, very non-specific, but very sensitive. If it's GLUT1 negative, it's quite unlikely to be perineurial lesion. So this was next case, a 40-year-old female, tumor in her cubital area. Sent as a consultation. I'll start with low power here. So here it looks like a multinodular tumor, but we have just fragments of the whole lesion, so hard to say. But in any case, the morphology, I think many people in this room know straightforward what this is. So it's very cellular, very alarming looking for people that are unaware of these tumors. There are a lot of mitosis, a lot of mitotic activity. So, and the clinical scenario is also often very alarming, rapidly growing lesion. Often it grows into several centimeters in size within 2 or 3 weeks. But still, this is a completely benign lesion called nodular fasciitis. And the key to the correct diagnosis are these areas where you have so-called pseudocystic spaces. So the separation of the tissue with extravasated red blood cells. This is almost a textbook example here in the center or here. So don't get confused by the cellularity and high mitotic activity. You shouldn't see atypical mitosis, or at maximum maybe 1, but definitely not widespread atypical mitosis. And it's usually tumor located in the subcutis or dermis, not deeper. So here again, this is textbook example of nodular fasciitis. Often you can find scattered giant cells. There were some here, but I don't know if I want to spend time looking for them. Maybe here. This is a myofibroblastic tumor, so there is a smooth muscle actin positivity, typically widespread, but it can be negative as well, or focal. So this is SMA, smooth muscle actin, with this so-called tram track pattern. So the cytoplasm or the cell membrane gets stained from both sides. I think it was submitted for consultation because USP6 FISH was negative. These lesions are typically rearranged in the USP6 gene, but in only about 70 to 80%. So I think the contributor got discouraged from the diagnosis by this, but the morphology is completely typical, so I wouldn't really care what the USP6 is. So next case was a 30-year-old male. It was a tumor in the inguinal area. On low power, it was a nodular lesion growing from the skin surface down into the subcutis. Again, very cellular spindle cell lesion. The epidermis was normal, a little bit atrophic, but otherwise normal, no dysplasia, anything. Again, this is a classic morphology for a tumor called dermatofibrosarcoma protuberans. This is a perfect storiform pattern. In some areas, I wasn't sure if I see so-called fibrosarcomatous transformation. That means long fascicles of spindle cells. I still think this is just a normal storiform architecture without transformation into so-called fibrosarcoma arising in DFSP, which would be more likely to metastasize, but I think it's not present here. In some other blocks, there was a helpful clue. I didn't mark this slide, so I'll go quickly through it. So the tumor is highly invasive and grows into the subcutaneous tissue, and therefore at the bottom especially you can see entrapment of skin or subcutaneous fat, such as here maybe. This is a very good example. Here the tumor grows into subcutaneous tissue and entraps the adipocytes. So this is typical appearance of dermatofibrosarcoma protuberans. The only useful immunohistochemical marker is CD34. You can see here diffuse expression. This is another reason why I think the transformation to fibrosarcoma is unlikely, because in such cases the expression gets usually lost in the fibrosarcomatous areas. So here you can, if you want to, if you are unsure, you can use FISH or some molecular studies. But here I think the morphology in IHC is perfect, so I didn't do any molecular. Okay, this is next case is very interesting for me at least. It's not mine. It was diagnosed a year ago by Zdeněk. Very great, really great diagnosis here. A skin lesion, adult person, elderly person, paravertebral skin. And so you see this ulcerated skin lesion, again, very cellular, quite infiltrative, unencapsulated. If you go on higher power, you see a lot of mitosis, including atypical mitosis, atypical cells, pleomorphic cells, quite bizarre morphology. And when immunohistochemistry was done for basically everything that should be done, so cytokeratins, so carcinoma markers, melanoma markers, leiomyosarcoma markers, angiosarcoma markers, everything was negative. The only exception, so the diagnosis which was definitely considered was atypical fibrosantoma. The only immuno which was positive was, or partially positive, was SOX10, but only in a small part of the lesion. I have to find it. Maybe I was, no, it's here. Okay. So this is SOX10. So you can see the tumor is completely negative, but at the junction, the epidermis, you can see remnants of nests of most likely melanocytes. There was also melan A, so I suppose this was also positive. So this is melan A, again positive. So this is most likely or very suggestive of a junctional nest in a melanoma. And therefore, the surrounding tumor is highly suggestive of so-called dedifferentiated melanoma, where you have melanoma cells that have lost the expression of normal melanoma markers. You can see that indeed the cells have prominent nucleoli, and otherwise the morphology for melanoma is very good. So more, genetics was added, and there was NRAS mutation, so this was diagnosed as a dedifferentiated melanoma. I was looking for cases of dedifferentiated melanoma, so that's how I found this case. So yeah, always, if you are thinking about AFX, do all the immunos and look at them carefully. Don't just look through the window. Another case, tumor on the finger, some adult person, doesn't really matter. It's a small tumor, very well circumscribed, composed mostly of hyalinized tissue, and then some epithelioid to spindled cells, which mostly look like histiocytes. But there seems to be some nests that look a little bit different, that look more epithelioid. For example, the cells here in the very center, those with epithelioid shape and ample cytoplasm. Also here, again, large epithelioid cells. So again, from H&E, this is, I think, very hard to impossible to diagnose, so you need some immunohistochemistry. Look at the other section. There's perhaps more of these large epithelioid cells, but this slide is dirty, so it's hard to see. So another section. I'll try to find some better looking areas, but I think the first section I showed was the best. Anyway, so again, I would start with the basic IFC panel as 100, EMA, CD34, cytokeratins, but also because of the location on the finger, well circumscription, and those large epithelioid cells, which were otherwise very bland, I would add two markers. One is clusterin, which is a marker of synoviocytes, and the other is some histiocytic marker. I added CD163. So this is clusterin, again, marker of synoviocytes, and you can see the large epithelioid cells are beautifully positive. And this morphology with this immunoprofile in this location is highly suggestive of tenosynovial giant cell tumor. But in this case, the lesion was probably quite old, and therefore the most prominent histiocytic and inflammatory background was kind of poor, lost. This is CD163, so you can see there is a bunch of histiocytes. Actually, most of the cells we saw were histiocytes. So this would not help, but in combination with the clustering positive cells, that's for me highly suggestive of tenosynovial giant cell tumor. But in this case, again, the inflammatory background is very poor. I'll try to find the cells again in H&E for you. So here in the center, these large epithelial cells are those that were positive for clustering. So actually, tenosynovial giant cell tumor is a tumor with synovial differentiation into synoviocytes. Andrew Fulp jokes that the real synovial sarcoma is a malignant variant of this tumor, which is, however, very rare. Most of these tumors are completely benign. This is another case, adult person. Again, the age doesn't really matter. It's soft tissues around the knee, and it's this multinodular tumor. It's hard to see at this low magnification, so I'll go on higher power. Multinodular tumor, myxoid stroma, and then we will focus on one of these nodules, perhaps here. You can see these strands or nests of eosinophilic epithelioid cells. Some of them are more roundish. It's generally quite eosinophilic cytoplasm, and this morphology here in the center, it's quite suggestive of extraskeletal myxoid chondrosarcoma, where this is a tumor with a sarcoma, malignant mesenchymal tumor, which is, there is no immunohistochemistry that can really help you. About 1/3 to 1/2 of tumors of cases expresses neuroendocrine markers such as INSM1. This is INSM1, very poor expression in this case, not very helpful. Some cases expressed as 100 protein. Basically, the only key to diagnosis is morphology, and if it's highly suggestive, just add FISH for NR4A3. So this case had the translocation by FISH, and it was extraskeletal myxoid chondrosarcoma. Next case, this was a 70-year-old guy with a tumor on his buttock. This is the last case I have here. So from lower power, it's predominantly solid tumor, highly cellular, some myxoid areas in some parts, but mostly it's growing in solid fashion, and mostly is composed of these spindled cells. Again, it's quite atypical, so it's suggestive of something more aggressive. So not a benign tumor. This papillary growth almost looks like some solid pseudopapillary neoplasm of pancreas in this area, but of course it's not. And immunohistochemistry, again, not helpful. This is an older case, so I must say, I recall I had no idea what this is. I kind of dismissed these more myxoid zones, and actually the diagnosis is the same. It's the extraskeletal myxoid chondrosarcoma. It's a rare so-called solid variant, which is more and more described thanks to like widespread availability of next generation sequencing. So we pick up these fusions which cause this tumor, and we retrospectively look at the morphology and then publish about it and pretend we are so smart. But it's very challenging diagnosis. I'll show you a paper. We've reviewed like all the cases in our archive some time ago, overall 17 cases, and of extraskeletal myxoid chondrosarcoma, and 2 cases had this solid morphology. So this is one case. This is a highly papillary growing tumor. I think this is the case I showed you. And no, sorry, this is the case I showed you. This is the solid growing case. Doesn't look like typical extraskeletal myxoid chondrosarcoma at all, apart from these small myxoid areas. And then another case, I think there was a case from Marianne Schweidler. This one looks more pseudopapillary. Again, by fusion testing, there was NR4A3 fusion. The funny thing is that they are like the classical EWSR1 NR4A3 fusions, which typically have the normal morphology. This is the most classical fusion, usually associated with conventional morphology. The first case I showed you was one of these EWSR1 and NR4A3 tumors. But then you have alternative fusion partners, such as this one or the other one, and those are much more likely to have one of the, to show the solid morphological pattern, so the deceptive one, the hard to diagnose. But still, the fish for NR4A3 will work here and will help you to pick up the right diagnosis, but very challenging scenario. Okay, that's all from me.
Just a Michael, the old one. I will show you something of a project that we would like to start of salivary glands. You know, I guess that you know the entity called sclerosing polycystic adenosis, now called sclerosing polycystic adenoma. And what I'm interested in are these intraductal proliferations. Which is the best one? For example, here. You may notice that they have interesting characteristics that are well known from other tumors. Yeah? They are sometimes undistinguishable from mammary aortic secretory carcinoma. And these proliferations are in 100% of sclerosing polycystic adenosis with intraductal proliferation. When I did immunohistochemistry, I found that these lesions, intraductal lesions, are very nicely as antiprotein positive as mammary aortic secretory carcinoma. You see, and they look really like mammary aortic secretory carcinomas. Yeah, and they are mammaglobin positive, not that deeply as antiprotein, but still very nicely. You see, that means another relatively typical positivity mammary secretory carcinoma, and especially they are STAT5 positive, which is quite specific for mammary aortic secretory carcinoma. Look at it. Be it as it may be, I'm not sure that it is mammary aortic secretory carcinoma, but it's typical of it, and it looks always like that, so that it would be nice to define them more, so that we are looking for more cases. We have sometimes cases with these proliferations. Probably will employ more fish because some cases are very old. Yeah? And the name of the project is secretary carcinoma-like proliferations in sclerosing polycystic adenosis lesions. Do you have some questions of it?
Yeah, I was mentioning that some cases were reported that secretary carcinoma are rising in scar.
It may be so. It will be that this is exactly what it would be. The last few minutes, and I will a little bit speak about something very different. Please show me the first. I will show about the plan of our laboratory. Yeah, we just yesterday we bought second house so that we own the two houses. They are this direction. For you, they are inside, and we would like to build one bigger house that would be of this time. This house is from Ostrava, but we would like to have the same these glass-like upper floors. Yeah, další obrázek. And it's the site from Rejskova ulice. If you would buy even the corner house that is between Rejskova and Mikolajská 3, they would allow us to build one floor more. Yeah, next. It's a site from drone. Yeah, and in this second floor they would allow us to build it more to the inside of the court, so that it would be the biggest floor, and we would make their lecture room for 350 people maybe. Yeah? All pathologists would be on the fourth floor. That is third floor. We are on the third floor. Here on this floor, it will go to the end of these two houses. That means there will be, including 7 new rooms for pathologists in our lecture room now. There will be 27 rooms for pathologists. I think we have only 7 from upstairs, yeah, so that there will be still 19 empty rooms, and I hope they will be clustered dermatopathologists together, I don't know, head together, yeah, and one's gastroenterologists together, one's hematopathologists together, yeah, so is the plan. I would like that this floor would be without steps, so that they could bring the trolleys with slides and without steps to go on the whole first floor. Yeah. Do you have questions about it? And we would like to have, I don't want to say bar, let's say cafeteria on the roof. Yeah. Seeing the whole Pilsen city, because it will be the highest house in the whole city of Pilsen. Yeah. And there will be a lot of greenery, and the whole street would be repainted on white color. That means the whole street would be quite apparent that it belongs to our laboratory. Okay, that's all. It's 3:30.